Hi students, here's sort of part one of, we're going to go back to the OR and talk about some C-arm review and OR cases that you may see as students and what's required for your C-arm comps as students. So just a quick overview again of the C-arm, the main parts of the C-arm. So the X-ray tube is the source of the beam, and that's down here. The image intensifier is up top. So it's going to go through the patient and then into this image intensifier camera. This is what captures the X-ray beam, converts it to an image, and then displays on the monitor. And most of our machines have this dual monitor as well. The collimator is within it, and it contains various, they call it apertures, all right, and determines the size and shape of your X-ray beam, and I'll go into that in a little bit more detail later on. And then the display monitor, the live screen when you're fluoroing is on the left side, and if you save and swap, it'll go over to the right. Okay, so we have both the 9800 GE OECs and the 9900s at our clinical site. Ways to make the exposure, you have a few ways. There's an exposure on top of the C-arm that we use all the time, but you also have the remote and the foot pedal as well. And the icon for fluoro is this I right here, and then boost, that higher dose fluoro, has the plus. And the boost will have an extra beep, an extra audible sound. So if you're hearing a double beep and your surgeon has the foot pedal, they're most likely hitting the boost. So you may need to ask them to hit the other pedal, okay? But also the remote has a swap or a save image button if you need it. And then pulse and low dose you'll find on the C-arm control panel. And low dose reduces the patient exposure by 50%. And pulse reduces exposure by 75 to 90%. In certain cases, we'll use pulse and low dose. For us, every fistulogram case, you can automatically put it on pulse and low dose without even having the surgeon ask you for it. Collimation. So you have two options on our C-arms that we have, and that is the iris, which is this one down here, or the leaves, which are just a straight sort of side-to-side leaf collimator. And you can kind of see the icons here. So this circular one is the iris, and then the leaves. And what you might need to do if you choose the leaves, you might have to collimate a little bit and then use this collimation rotation button. So if it's sort of cutting your anatomy off at an angle, you may have to rotate it so you can see whatever sides. But collimating always improves your image, right? Go back to your basics. It's going to reduce the scatter. So your larger patients, your larger parts, if you're using a lot of dose to try and get through, collimating is going to improve your image by taking some of that scatter out. Going back, just a quick reminder of your cardinal rules, right? Time, distance, shielding. So time, only make the exposure when you're being asked. And then if the surgeon asks you for live fluoro, but they're not looking at the screen, don't keep fluoroing. Take your finger off. Save yourself the dose, your patient, and everyone else in the room. Distance, step back. The scatter is 6 feet from the patient, so be aware of where the patient is. Can you step back a little bit? Can you step back and use the remote when possible? Is the C-arm in lateral position? Can you step to the side a little bit and not get as much dose? Just be aware of where you're standing, where your dose is coming from. Shielding, make sure you have a full lead and a thyroid shield. And also, you need to announce when you're going to take an x-ray. And I usually say, everybody have lead on, do a quick look around the room, make sure everybody has lead before you go and make the exposure. And monitoring, make sure your radiation badge is on collar level, and it has to be outside the lead apron. Obviously, if it's under the lead, it's not picking up any dose. One of the major concerns in the OR is making sure that the patient does not get an infection. So you're going to see aseptic technique and asepsis as a term used a lot in the OR and surgical information. But essentially, the goal is to prevent contamination of the open wound by isolating the OR suites from surrounding non-sterile environments. That's why we enter through the side door. Once the room is open, everyone wears a mask. You always just watch anything you could possibly contaminate by accident, and always go by, if you see something, say something. Even if you might not be sure if you touch something, you are much better off to let them know. Say, hey, I'm not sure, but I think I might have touched that. If you can save your patient an infection, that's the goal. Some OR rules. Source to skin distance for when using the C-arm, which is considered portable fluoroscopy, it shouldn't be less than 12 inches. So be aware of where your source is and where the patient's skin is. Just like fluoro, the fluoro time should be kept under 5 minutes of fluoro, and it will have that alert bell, right? It has to have that audible noise per the FDA, just like your fluoro machines do. And it'll look like that little bell icon, similar to that of their fluoro table. Always face your sterile fields. Anytime you're moving around that room, always face any of those trays or tables or anything blue, right? Blue, when in doubt, if anything's blue, it's most likely sterile. So be aware of it. There are some clear things in the OR that are sterile, and one of the main ones is your C-arm bag. That's clear. Don't touch the outside of that. Watch out for the microscope drape that's in the room, because that's clear as well. Those are sterile even though they're not blue, and the microscope drape takes forever for the OR staff to drape it, so they will not be happy if you touch it. Watch out for your OR cap, especially those bouffant ones that kind of go up high. When you're wearing your OR jacket, make sure it's snapped and it's not sort of opening up. Never walk through that sterile corridor. Don't go between the patient on the OR bed and that sterile table that your scrub tech has, okay? Your blue OR scrubs also never leave the hospital. They go back in the machine when you're done. For your program, you need to have 2 C-arm comps. One has to be an orthopedic C-arm comp, and one has to be non-orthopedic. What counts for comps? We usually ask that you have at least an orthopedic comp where you've done AP and laterals and some angling included. If your surgeon moves, say, the ankle into AP and lateral position for you, we don't count it. So you need a humeral fracture that's in a beach chair, a tibial IM rotting, a femoral IM rotting, something that requires you to show us some confidence in moving the C-arm, going AP and lateral, making exposures, being aware of angles if needed, and that you can follow one of those orthopedic surgeons and be confident in that. Your non-orthopedic C-arm, it can be the intraoperative cholangiogram, retrograde pyelogram. If the surgeon uses the foot pedal for the case and makes the exposures, we don't count that. So your fistulagram or your portacath studies where our surgeons use the foot pedal and make the exposures themselves, we don't count that as a competency because you're not the one making exposures, so all you're doing is saving images. So really being aware of your schedules, have a plan. What cases have you seen? Have you worked with that surgeon before? Your non-orthopedic C-arm cases, they're mainly going to be over in Chestnut. So make sure you're checking the Chestnut schedule for the day if you haven't been over there yet, and really sort of planning your day. Where you're going to go, what are you going to comp on, what do you need, check with your other students that you're with, what have you seen, what do you need to see, and sort of really kind of run your show in the OR. All right, I will see you for part 2 in a minute.